Hi, everyone, and welcome. I'm Shelley Gunther, Clinical Marketing Manager at Clarius. Thanks so much for joining us today for another highly informative webinar with renowned emergency physician and educator, Dr. Tom Cook. You're among over a whopping 4,000 clinicians who registered for today's popular session, Emergency POCUS, Mastering Trauma Care with Handheld Ultrasound. Time is of the essence when patients present to the ED with trauma, and point-of-care ultrasound can play a key role in the initial evaluation of various trauma-specific applications and can guide decision-making in minutes. In a moment, Dr. Cook will share life-saving POCUS techniques for evaluating and managing a variety of trauma cases. And today, we'll be showcasing the recently FDA-approved and, as of 1 week ago, cleared for sale in the EU and Australia, Clarius PAL HD3, our new wireless high-definition scanner that fuses a phased array plus a linear array on a single head. Now, following the presentation, I'll do some live scanning to show off the new Clarius PAL, so please stay tuned. And you can use the questions icon at any time during today's session to ask questions, and Dr. Cook will address your questions in the live Q&A following the presentation. So let me now introduce you to our host for today's event. Dr. Frankel is an emergency-trained physician trained in California, and he's a passionate POCUS educator. He's been using point-of-care ultrasound his entire career. He practices in a busy academic teaching hospital here in Vancouver as an emergency physician and serves as the chairman of our medical advisory board. Welcome back, Dr. Frankel.
Thanks, Shelley, and good to be here on a topic that's near and dear to my heart, something I do pretty frequently in my clinical practice. And to set the stage for our discussion with Dr. Cook, we were going to take a little bit of a different turn today and focus more on point-of-care ultrasound education. The first paper I wanted to highlight is this really interesting retrospective review around point-of-care ultrasound, particularly among emergency medicine residency programs. And it found with a survey over this 10 years that, like we expect, point-of-care ultrasound is really increasing among residents. Year by year, the number and indications of scans are increasing as residents are graduating from their programs. And we can imagine that these are percolating out to practitioners as they leave their residency training and move out into practice. The next one is sort of on the next paper on the same topic, similar, was how these thought leaders in point-of-care ultrasound talk about evolving concepts in emergency medicine and how point-of-care ultrasound has really evolved. And the thing I really wanted to highlight was how the cheaper the technology becomes and the more widespread it's become in our clinical practice, we're also seeing this parallel of point-of-care ultrasound becoming much more integrated into our clinical practice and the use of patients, and the applications only continue to expand. And to bring it all back to where point-of-care ultrasound really started in emergency medicine, just to highlight its use in trauma, which is going to be the focus today, on really this rapid diagnostic power to guide our clinical decision-making. And what we've found over the years is how what we learned in emergency department can also be integrated to all points of the patient journey. And this goes to pre-hospital level in the ambulance or in the field, to the trauma center or emergency department when they arrive, but even beyond, once they go into the hospital, to the OR or into the intensive care unit or an inpatient ward where they're going to be managed longer. So before we jump into the real topic today, we just wanted to put up this quick poll. We know we have users across the world from different areas of practice, different expertise, and want to know, how often are you using your ultrasound on your trauma patients? Is it something you're just learning today, rare occasion, or is it something maybe even in your daily practice if you work in a busy trauma center potentially? Okay, we'll leave that on for 1 second. That's a pretty quick poll. We'll close it out here to save time for our speaker. And let's just see where folks are at. Yeah, okay. And so we have a third of you just learning today, which is really great. So, and some even on the daily practice. So really wide range of expertise, which is what we love to see, because it means everyone's going to learn something today from our esteemed speaker, who we're always happy to have back, Dr. Tom Cook. After leaving the Army in 1996, Dr. Cook began practicing civilian emergency medicine in South Carolina. And since 2001, he's acted as the Emergency Medicine Residency Program Director at the University of South Carolina. He initially developed the emergency ultrasound curriculum and then founded the nationally recognized Third Rock Ultrasound and the Emergency Ultrasound course. In the last 20 years, he's presented hundreds of talks to an international audience and is beloved wherever he goes to speak, and we're so happy to have him back. Tom, I'm going to hand it back over to you.
Hey, thanks a lot, Ron. That was an over gracious introduction there, as usual. but I'll do my best anyway. So happy, hello to all 4,000 of you. I'm completely humbled that you would want to spend a little time with me talking about ultrasound, which is obviously what I love to do. And today's topic is trauma ultrasound, which if you're in a critical access setting, gosh, maybe you don't use this, but when it does show up, boy, it sure is nice to be able to do it. And then in my practice at a big trauma center where we use it multiple times every time I'm on duty. All right, today, this is what we're going to talk about. We've got to go over what scan protocols are used for trauma patients, and most of you know this is the FAST exam. We'll also talk about the different types of pathology that can be picked up with ultrasound and what those types of pathology we'll look at when you're scanning. And finally, we'll go through the very extensive list of pearls and pitfalls, which I've learned through many painful experiences myself over many, many years. Of course, we have to start the lecture with a case, and so this is a dance club in my city of Columbia, South Carolina, and of course, dance clubs being what they're, a couple of guys get into an argument, and there's some shoving, and they get kicked out, and they go in the parking lot, and one thing leads to another, and somebody's got to pull a gun because it's the United States, and that's what we do here. And of course, somebody gets shot, and they come rolling to my ED. And as you can see from the vital signs, they're tachycardic, they're hypotensive, and they're tachypnic, so they're a pretty sick patient. And of course, we strip them down, and the first thing we see is a bullet hole in the right flank, just below the scapular tip. And so we start our FAST exam, and we start with the right upper quadrant. We get this image here. Then we go to the left upper quadrant. Then we go down to the pelvis. Then we're going to image the heart. And of course, we're going to finish up with the lungs. And what we're going to do with this is come back a little bit later and figure out, okay, what's wrong with this patient? And, what do we need to do next? What's our next management decision? Of course, we're going to circle back, as I said, at the end of these slides. So for just looking at free intraperitoneal fluid and trauma, there are three methods for doing this. And the first one started back in the 60s, which was deep peritoneal lavage. And probably most of you are not old enough to even remember ever doing this. I am old enough to remember having to do this quite a bit, but it has all sorts of problems with it. It's invasive, obviously. It's way oversensitive. It results in a lot of non-therapeutic laparotomies, and it's not suitable in pregnancy. In the 80s, of course, we had CT come along, but there was a problem with that, and that you had to take the patient out of the resuscitation bay over to the CT scanner, which was often on the other side of the hospital. In those days, the 80s CTs were really, really slow. And by the time they got back to the trauma bay, sometimes they were dead. And a lot of times they were just in worse shape anyway. So that wasn't so great in those days. Of course, now it's much more quick than it was in those days. But CT is very sensitive and specific. Of course, it's very expensive, requires highly trained personnel, requires transport out of the resuscitation area. And then comes our hero, which is ultrasound, which of course is fast, easy to perform, doesn't have a lot of high-end personnel requirements. It's more accurate than DPL. And finally, it's non-invasive. So what kinds of pathology would we look for in trauma patients? Well, let's start with the peritoneal cavity first. We know that in trauma, the most commonly injured organ is the liver. In blunt trauma, the most commonly injured organ is the spleen. Also in blunt trauma, we can get a lot of pelvic injuries, usually from pelvic fractures. And when it comes to bowel, those are most often injured in penetrating trauma. Another important concept to understand is that blood will always go to the most dependent part of the peritoneal cavity. And when our patients are supine, which inevitably they all are, the most dependent area of the intraperitoneal cavity is going to be the right upper quadrant, specifically that area between the right lobe of the liver and the right kidney, which is in fact the most dependent area of that particular cavity. The second most dependent area of the peritoneal cavity is going to be the pelvis. For the thorax, we're going to be looking for three things. We can look for pneumothorax, we can look for hemothorax, and we can also look for pericardial fluid. Now, scan protocols. We use this thing called FAST, which in the old days stood for focused abdominal sonography for trauma, because we were only looking at the intraperitoneal cavity. But now we're more advanced because we use it for the thorax and for some other things, so we call it focused assessment with sonography for trauma. So we were very clever. We didn't have to change the name of the acronym. We could keep the same letters, but stray out of just doing the peritoneal cavity. So when we do a fast exam, at least the current state of the art is we start here in the right upper quadrant, we do left upper quadrant pelvis, the subcostal view of the heart, and then both of the lungs. All of these different views shouldn't take more than 30 seconds to do. So your total exam is just a few minutes. You do it simultaneous with resuscitation. That's an important point to consider as well. And finally, you evaluate both the peritoneal and the thoracic cavities. For these examinations, classically you're taught to use a curvilinear array transducer, but I actually use the phased array transducer. I can get very, very good views of the peritoneal cavity with a phased array. And on my particular device, I can also do lung exams with that particular transducer. So the first place we're going to look is the right upper quadrant. And what's nice about the right upper quadrant, besides it having Morrison's pouch, which as we said is where the blood's going to accumulate first, is that you have the liver. And the liver is our friend. It's the biggest organ in the intraperitoneal cavity, and it's squishy and it's dense, so it really allows the ultrasound to penetrate into the body. And because the organ's so big, we can place that transducer in multiple positions, and we're still going to get the same fundamental view of Morrison's pouch and be able to see that collection of blood in there from trauma. Now, how much blood does there need to be in order to get a positive study? Well, it depends, of course, on the size of the patient. If you're a small person or a child, you may need just a couple hundred cc's. If you're a big guy, it might need as much as 600 cc's of intraperitoneal bleeding before you're going to get a positive study. Contrast that to the DPL, you only need 20 cc's. I mean, 20 cc's, we don't need to go to an operating room for 20 cc's of blood. That's what you get taken out of the lab when you give your blood for some lab tests. CT, a little better, 100 cc's. And then finally, ultrasound is about whatever, two to 6 times as much as you would get a positive study on CT. So when you're doing that right upper quadrant examination, you want to look at 4 different things on that view. Of course, you want to look at Morrison's pouch, but you also want to make sure you see the inferior tip of the liver. You want to see the subphrenic space, and you also want to look above the diaphragm into the pleural space. So here is a normal view of the right upper quadrant. And here are those 4 areas that we want to see. We want to see, of course, Morrison's pouch. We want to see the caudal tip of the liver or the liver edge. We want to see the subphrenic space between the liver and the diaphragm. And then we want to take a peek into the right hemithorax and see if we see anything in that area as well. So here's an obvious example of a positive study with a ton of fluid in Morrison's pouch. This is a no-brainer. And it's something you can pick up within seconds when you start this evaluation of seeing this particular patient. And here's another one where you look, and boy, that doesn't look too bad at all. So you're sitting there scanning, and then you work your way down towards the liver tip. Whoa, wait a minute, there's a fluid collection there. And if you walk right here, it makes its way all the way around the inferior edge of the liver. So that is a positive study. If you just looked at Morrison's pouch, you would have missed that. This is a really obvious one where there's a ton of fluid. Here's the liver edge right here, and you can see there's fluid all the way around the liver. So that's an obvious positive study. Now, the other thing you want to be careful about is looking at that subphrenic space. So this is when blood has traveled up around the liver and gone up the side between the parietal and the visceral pleura on the liver. And this is what that'll look like, where obviously you see the liver here, this bright white line, that's the diaphragm. And then we see fluid between the diaphragm and the liver. Now, the second place we're going to look after the right upper quadrant is the left upper quadrant. Now, the left upper quadrant, the window is the spleen, which is a teeny little thing relative to the liver. And so your window is much, much smaller, and that makes this exam more difficult. But again, we're going to look at 4 different areas of that particular image to see if there's evidence of intraperitoneal fluid. And that's going to be the splenorenal space, the inferior pole of the spleen, the subphrenic space, and finally, again, we'll look above the diaphragm into the left hemithorax. So this is a normal study of the left upper quadrant. We see the spleen and we see the kidney, and we want to, again, make sure that we're looking at all 4 of those areas that I just mentioned. So we want to see that space between the liver and the kidney. We want to see the inferior pole of the spleen. We want to see that area between the spleen and the diaphragm. And of course, we want to look into the left hemithorax. Now, this is an exam, left upper quadrant. This is very easy, right? There's fluid there between the left kidney and the spleen. That's, again, very, very simple to pick up. Now, in this one, don't see it initially, but then if you look, the blood, the fluid is going up over the superior pole of the spleen right here. And here's another one. We don't actually get a great view of the kidney, but we do see this fluid here again around the inferior pole of the spleen. That's why you just got to make sure you see the inferior pole, because sometimes blood will kind of sit in there and you'll miss it, and there's nothing between the spleen and the kidney.
It's a good opportunity also, Tom, to really highlight that these scans are dynamic. You don't want to just settle with a single view, right? And just be like, oh, I see the left upper quadrant. You really kind of need to search and do a little bit of a complete survey around the area of interest.
Absolutely. And you see I don't want to pick on the trauma surgeons, but a lot of times their residents, they get one image, they go, yep, it's fine. And you gotta, we'll get to that in our pearls and pitfalls section, how to get burned. Now this one here, of course, you see the kidney here. Here's the spleen, and you can see the superior pole of the spleen is just ripped to shreds, and all that fluid again between the diaphragm and between the spleen. That's a pretty dramatic case. Now this one's an old one I had to pull up from the archives, and the reason I put it in here is here you see this spleen. You don't really see the kidney, but there's a big tear in this spleen. I mean, this is obviously something wrong with it, right? But you don't see a lot of free fluid around here. And, you kind of scratch your head and like, how is even that possible that you have that big of a rip in such a vascular organ and you don't see anything? And this brings up a really important point, which is, again, when the patient's supine, the most dependent area in the peritoneal cavity is Morrison's pouch. So you can have a tremendous injury over here, and all the fluid is over here. So the right upper quadrant is positive, the left upper quadrant is negative. Again, but you got to make sure that you don't just assume it's coming from the right side of the body. It certainly could come from the left side of the body, giving you a positive study on the right. The other thing and here again, this slide just demonstrates that the right lower quadrant is more dependent than the left. But the other thing you have to keep in mind is this old thing from your anatomy class a million years ago, which is the frontocolic ligament, which is that ligament which comes off the splenic flexure of the large bowel and goes up to the parietal peritoneum. And what that ligament's going to do is prevent any blood from an injured spleen to go down the left paracolic gutter into the pelvis. So once again, that fluid from here is going to collect in the right upper quadrant, particularly if the patient's been supine for a relatively long period of time. All right, we did right upper quadrant, we did left upper quadrant. Now it's time for the pelvis. And we got two flavors of pelvis, right? We got male and female. So we'll start off with the male. And this is a sagittal cut in a male. So just to reorient, this is anterior and this is caudal and this is this is cephalad and this is caudal. And obviously we see the bladder here and the prostate exam is right there. Now, what we want to pay attention to in these views is something called the rectovesicular pouch, which is the potential space between the rectum and the bladder in the male. And when we do that, we want to just look to see if there's a fluid collection right down in here. And if we see that, that should tip us off, particularly in males, that there's some free fluid in the pelvis. In females, it's not. You can see in other situations. In a male, that's pretty rare. And then also we need, of course, to look over the dome of the bladder itself. And this is a pretty dramatic video here. We have a lot of fluid down here. We see loops of bowel, and that fluid is extending all the way up over the dome of the uterus. So this is a very positive study, and something that you would probably take care of straight away. Now, we also have to consider the transverse view. We could also call that the axial view. And one of the things you have to be aware of is that when you're doing a transverse view of the abdomen, you can angle the transducer down into the pelvis so you're not even in the peritoneal cavity. In fact, you can see the trajectory of this yellow line here. It doesn't even go into the peritoneal cavity. In fact, it goes through the prostate. But we can also angle that same signal more cephalad, and now we'll pick up parts of the peritoneal cavity where we can potentially see fluid collections. And so here's an example where we've angled the signal so that it's not going through the peritoneal cavity. We see the bladder, and this structure right here is the prostate. And the prostate, of course, is extraperitoneal, so we would never see free fluid in this particular view. But if we take that transducer and we angle the signal more into the peritoneal cavity, suddenly, wow, there's a lot of fluid right here. And that's a very, very positive study. So you have to make sure you've got that transducer angled in the right way. Now we'll move over to the female pelvis. And this is a sagittal view. So again, to orient, the top of the screen's anterior, bottom is posterior. This side of the marked side of the screen is cephalad. And of course, we see the bladder here. There's the fundus of the uterus, the body of the uterus, and there's the cervix going down to the vagina. Now, we can look on these particular patients. What we need to look at with females is we're going to look at the recto-uterine pouch. Okay, that's the potential space between the uterus and the rectum, and it's also called the pouch of Douglas because what doctor doesn't want to get his name on something? You know, everything has to be an eponym in medicine. In any event, on this picture, still a sagittal view here. You got the uterus right here, and right down here, you see this little fluid collection. Now, in women, you can see little fluid collections for a bunch of stuff. In fact, that famous metal schmerz thing where they ovulate in the middle and spill out a little fluid, you can see that in all kinds of female patients. But in a trauma patient, your ears should perk up just a little bit there going, there's some fluid in there. Maybe there's a more significant problem. Maybe there's some bleeding going on. Now, of course, you also need to look above the uterus as well. And this is a crazy picture, but I'll just orient it. Right here is the uterus. This is the bladder, which is all smushed down. Here we have free fluid between the uterus and the bladder. It's very anteriorly positioned. And then we have a whole bunch of fluid right back in here, which is going over the fundus of the uterus. So this is, again, a very positive study. And sometimes if you get lost and you don't know what you're looking at, I always just pick out one thing that you can identify and then put all the anatomy back together and helps out. Now, as far as the transverse view in the female pelvis, same problem that we had with men. If you angle that signal too far caudal into the pelvis, you won't be anywhere in the peritoneal cavity. And so what's happening is you're not examining what you want to examine. You need to angle that signal so that you're actually sending it through the peritoneal cavity and looking for free fluid. So here's an example where you're looking down into the pelvis. This is the cervix right here. Here's the bladder, but you're not going to see any free fluid if it's there because you're not actually sending the signal into the peritoneal cavity. What you really need to do is angle that signal more towards the head, and now you see the uterus is just swimming in blood. And of course, this is really important to figure out, and obviously important not to miss. So now we've done right upper quadrant, left upper quadrant, pelvis. Now we're going to go on to the fourth thing, which is the heart. All right. Traditionally, what we do is we use a subcostal view of the heart in the FAST exam. You can use all the other views. I'm not going to get into that today because we only have so much time. But when you use a subcostal view, using the left lobe of the liver right here to take a look at the heart, and the first thing the ultrasound signal is going to make contact with is the free wall of the right ventricle. That's what you're going to see first. And of course, you can do the rest of the anatomy. Here's the right atrium, left ventricle, and left atrium. Now, excuse me. When you have intrapericardial fluid, you'll get a very sharp demarcation between the left lobe of the liver and that fluid, of course, which in the acute phase is entirely anechoic. All right. That's what you want to see. And that's why everybody sort of likes the subcostal view. Plus, if there's stuff going on, procedures and what have you at the chest, you're still theoretically not in their way when you're trying to look around. Now, when you have fluid in the pericardium, you are developing a very dangerous pressure situation because that sac is not distendable. And so if the fluid goes in there, the pressure inside the sac starts to go up. And we know that the pressure effects will have be much greater on the right heart than on the left heart. And that's because the right heart has lower pressures normally. And so at some point, a tipping point is reached. And what happens is that the pressure inside the pericardial sac exceeds the pressure in the right atrium at the end of diastole. Remember, in diastole, that atrium is contracting and squirting that blood into the right ventricle. So the pressure goes down. And if the pressure in the sac is greater, the free wall of the right atrium starts to collapse. And then at some point, the same thing happens with the right ventricle at the end of systole. So what happens is you get this situation where the right atrium's here and the right ventricle's here. And so what happens now is at the end of diastole, you can see right here, the free wall of the right atrium is starting to collapse. And then at the end of systole, the free wall of the right ventricle is starting to collapse. So there's a lot less blood that can get into the right heart because the pressure's gone up. And that leads to less loading of the left ventricle. The cardiac output starts to drop dramatically. And that is what comes up as a lethal event. This video right here is just a perfect example of that. You can see the right heart right here is completely collapsed. There's no blood going into the left heart. And if this patient doesn't have that fluid drain in the next 30 seconds, they are going to die. And even though we did get the fluid out and got this particular patient back, that patient did in fact die a few hours later. Now, when you're looking at fluid in the pericardial sac, how much blood is bad? And the point here is that you don't need much, 100 cc's or so, and you're probably going to kill the patient because that sac cannot dilate very, very quickly. Now, you do see these pericardial effusions, they're massive, you know, but they've been around a long, long time because that sac very slowly can distend. But if you squirt a little blood in there from trauma acutely, boy, that'll kill your patient. All right, right upper quadrant, left upper quadrant, pelvis, heart, we're up to number 5. This is the lungs. And of course, nobody thought of using ultrasound for lungs all those years ago because we know ultrasound doesn't go to air. But now we figured out, oh, it's actually great for it. And the things we can look for are also potentially life-threatening. So we'll start with pneumothorax. And for this, traditionally, you're going to use a linear rate transducer. But for bigger patients, which we have a lot of in my area, we may use a curvilinear transducer because it's lower frequencies and you get better penetration. Now, to diagnose pneumothorax, we have to remember 3 fours, okay? First 4. We're going to remember the probe positions on the right side of the chest. So the first one is at just under the clavicle at the midclavicular line. The second position, just medial to the nipple. Third position, just lateral to the nipple. Fourth position, mid-axillary line, just below the nipple. Second 4, those are the positions on the left. So number 1, again, mid-clavicular line, just under the clavicle. 2 and 3 got to be moved a little bit more lateral because you got the heart beating right in this area right here. So you'll get artifact from the heart. And then 4, again, mid-axillary line, just below the nipple line. What we're trying to see with this examination is the pleural line. And the pleural line is the combination of the visceral pleura over the lung and the parietal pleura lining the chest cavity. And what we'll have to do this is 4 steps. So that's the third 4. The first 4 is the positions of the probe on the left side. The second 4 is the positions on the right side. And these are the 4 steps to find the pleural line. The first thing you're going to do is place the transducer oriented so that you're cutting through the ribs in the short axis, okay? So it's a sagittal cut. And when you look on the image, you can see very clearly here's a rib and here's a rib. So that's the first thing you do. The second thing you're going to do in this exam is look for that rib interspace between those 2 ribs. The third thing you're going to do is look for that white line. That's the pleural line. And the last thing you're going to do is look for motion along that line. That's the visceral and the parietal pleura rubbing against each other. And that tells you that you do not have air between those 2 structures. Here you see an example. It's normal. Okay, so you have a rib here, that's 1. Then you have the rib interspace 2. Then you see the white line 3. And then you see the movement 4. 4 things you got to do in that exam. Now, what about a patient with pneumothorax where there's air between the visceral and the parietal pleura? Now you can't see the visceral pleura anymore. You don't see that moving activity here at the pleural line. That tells you that you have a pneumothorax at that rib interspace. Doesn't mean it's big, doesn't mean small. Obviously, you see a lot of this over many interspaces. It tells you it's a lot bigger pneumothorax, but only at one interspace, it just tells you it's that interspace. Now, here again is an example. This is normal where you see the sliding, and here on this side, you don't see the slide. That's pneumothorax. Now, here's what we get with a curvilinear transducer, all right? You get a bunch of rib interspaces. Here's a rib, here's an interspace, here's an interspace, and you see sliding on all those interspaces. But on the right side of the screen, we see 2 ribs, we see an interspace here and here, no sliding. So that's an example of diagnosing pneumothorax with a curvilinear rate transducer. Next pathology is hemothorax. I just had this case the other night when I was on duty. A kid had been hit by a boat. But here's an example of looking at the right hemithorax, and this is a normal exam. You have the liver and the diaphragm here. Now, what's important to understand with looking for hemothorax is this artifact called mirror artifact. And I'll briefly explain this, but this is a normal image of the right hemithorax. This is the liver, which we know is our friend because it sends ultrasound signals through it. Then we got the diaphragm, which is very, very smooth. And then we have the lung, which is filled with air. Well, if you take this smooth diaphragm and you put something behind it, which is highly reflective, lung filled with air, suddenly you have a smooth reflective surface, i.e. you have a mirror. And that's exactly what you get when you look at this in motion. Here's the liver, here's the diaphragm, and on the other side of the diaphragm, it looks exactly as it does on this side. So both sides of the diaphragm show you the same image. It's a mirror image. And what's important to remember is that is normal. Okay, that's normal. Now, what happens when you get fluid in there? That's what you see here. So now we see the liver, now we got the diaphragm, but we have all of this anechoic material here. It's not a mirror anymore. Now the ultrasound signal can come through the chest and go through this through this part of the body, and you get this anechoic picture there. So another thing that we can look for is something called spine sign. And again, looking on the left, this is normal. We see this mirror image on either side of the diaphragm. While over here, we see an anechoic fluid collection above the diaphragm. And look down here. This area right here, that's a vertebral body. That's a vertebral body. Here's a intervertebral disc, and here's another intervertebral disc. So those things are flexible, and they'll allow for the transmission of ultrasound signals. So this is spine sign, and that's another indicator that there's something else in the chest besides air. This is a case I just had a couple of months ago from a gunshot. You can see this is the left side of the chest from the diagram on the left side of the screen. This is the spleen, this is the kidney, the diaphragm is right here, and you can see there's some fluid as well as some echogenic material. This person had been shot, and it was a delayed response, so we didn't get him for a few hours. And you can see the blood clotting and sort of floating around in the left chest. All right. Now you finished your FAST exam, right? Right upper quadrant, left upper quadrant, pelvis, heart, lungs. You got all this information. Now, what are you going to do with it? And this is the clinical perspective. So if the patient has abnormal hemodynamics, all right, they're tachycardic, hypotensive, tachypnic, et cetera, and you have a positive FAST, some type of surgical procedure is in their future, all right? Now, if it's in the intraperitoneal cavity, that might be going to the operating room and having a laparotomy. If it's just in the pelvis, maybe it's embolizing a pelvic, the arteries in the pelvis for a pelvic fracture. If it's a hemothorax, it might mean a chest tube, could mean a lot of things. If you have abnormal hemodynamics and the FAST is not positive, it's negative, then you're going to keep going with your resuscitation, whether that's IV fluid, blood products, what have you, and then rescan them. And we're going to be hammering this idea of rescanning the patient in trauma quite a bit. Now, how about they have normal hemodynamics and the FAST is positive? This is the case at, in almost every ED, certainly every trauma center, off to the CT scanner for a pan scan. If it's negative, obviously you're probably going to pan scan anyway, so you are in my place, but this is another patient you would observe and or rescan with ultrasound. All right, now for probably what I think is the best part of this lecture, which is all the pearls and pitfalls. These are the hard-learned lessons that you have over a 30-some-year career. And hopefully I can give you a few things to avoid getting into trouble. So the first one we'll talk about is this idea of monitoring the intravascular volume. We covered this in a resuscitation module not too long ago, but that's simply using your ultrasound to look at the inferior vena cava and looking for its capacitance, in other words, how well it moves with respiration, but also its size. And this can be very, very helpful in trauma case. So the example on the left, you have a relative hypervolemia, right? Like you get this big dilated inferior vena cava and the hepatic vein. You wouldn't expect to see that in trauma because usually you're losing blood, not gaining blood. But in this, if you see this situation, there should be a siren that goes off in your head because there's two things that are going to cause something like this. That's a tension pneumothorax or a pericardial effusion. So if you see that, that's a problem. And also, let's not forget, this could be somebody with congestive heart failure who was in a trauma. So, we can't overlook that they have some other type of comorbidity. Now, on the right, you can see it's flat. And this is the kind of thing that we would expect with a trauma patient, right? They're losing blood, they're losing fluid, and they'd be relatively hypovolemic. So that's something that we'd see as well. But we can also monitor their response to fluid resuscitation. All right, the second one, repeat the scan. Repeat the scan, repeat the scan. Don't get complacent in saying, I saw it one time and it was negative, or there was just a little ditzel here or something, and then move on. If these patients are unstable and you haven't found a suitable reason for their bleeding and or you just found a little something, Go back and look and make sure that's not accumulating. If it's accumulating rapidly, if this is changing over the course of 10 or 15 minutes and getting bigger and bigger, boy, your trauma surgeon wants to know that, because they might be trying to decide between going to a CT scanner and going to the operating room. Number 3, right upper quadrant fluid is pointy. What do I mean by that? When you look at the right upper quadrant, this fluid right here, you can see is pointy. It comes to a point right here. This has to be contrasted with this area right here. Now, of course, we have right upper quadrant fluid here. We see the pointiness, but this right here is just the gallbladder. And sometimes you get these weird gallbladders. They're a little long, and you're looking for something positive. Right when you're ultrasounding in the heat of the battle, you want to find something positive so you can feel good about yourself. Don't get fooled into thinking that is free fluid. On the left side, the thing you'll get burned on is they chugged a bunch of beer before they got in their car accident, and their stomach's full of fluid, and people will see that. And I wish I had included that video, because I actually convinced a trauma surgeon to take somebody to the operating room because I saw a stomach full of beer. He wasn't too happy with me after that, and I learned my lesson. All right, number 4. Chest x-rays are terrible, okay, for 2 traumatic injuries that we've covered today, which is pneumothorax and hemothorax. They're about a coin flip, okay? Trust your ultrasound in this situation. The chest film is not so great. Now, if you want to look for the chest tube went, I agree with that. And if you want to look for the endotracheal tube went, that's a good idea. But don't use it to diagnose pneumothorax and hemothorax exclusively. It's a bad idea. All right, number 5. Left upper quadrant. We've already said this, but the left upper quadrant is not a sensitive test. It's a specific one. Here's a case. You're looking at the spleen. I don't really see anything that jumps out at me and says there's any fluid in there. Maybe I could convince myself it looks a little funny because I know what's going on. But you wouldn't look at that and say, boy, that's positive. But here's the CT scan. You see there's a terrible rip right through the spleen. So what's going on? Like, how is that even possible that it's there? And we already told you about that. The fluid in the left upper quadrant will move to the right, particularly that patient is supine for a long time. This was the actual spleen from that case that they pulled out. Now, come on, man, that thing looks terrible, and yet the study was negative. So don't get fooled when you say the left upper quadrant is normal. The answer for left upper quadrant trauma is CT. Number 6. All right, blood clots. You'll see them occasionally, particularly that patient's been down for a while. Invariably, somebody runs off the road, hit a bunch of trees. They find them in the morning. They've been there for 5 or 6 hours. And when you go to scan them, you'll see these little echogenic material in there. But usually when you do see blood clots, they're in a sea of other blood. So you'll see them floating in stuff. It's not like a big sort of solid gelatinous mass in there. It's usually these clots that are floating around. And again, I can't emphasize enough. It takes time for these clots to form. So you're not going to see somebody with a short run time. They were down the street from the emergency department and got in a car accident. You're not going to see it then. All right, number 7.
And the stomach, I've seen the stomach where people thought it was clot, but the stomach, to your comment earlier, it's really sparkly. All the bubbles of the beer and what they drink. It's sort of its own signal. Once you see it a few times, you can recognize it.
Yeah, I got to put that video in there. Next time I get a good beer.
Self-scan.
Yeah, that'll be me later on this evening. Point at number 7. How much blood is bad? Well, the answer is all blood is bad. But here's what happens. You do your study. You got a little sliver here. You're going to tell, like, hey, it's a little pus, okay? And then you forget about it, all right? This goes back to the earlier point of repeat the scan, repeat the scan. So I've got my iWatch. I'm doing my free Apple commercial here. I'm expecting some money from Apple. But I just hit the little 15-minute timer on my watch because I can't remember anything. I'm old. And it'll fire. And I'll go, I got to go back and scan it. So be vigilant. That little thing may look a lot worse when you get back 10 minutes later. And then you go, hey, this guy's really bleeding fast. You might want to change whatever decision you were going to make. So repeat the scan, repeat the scan, repeat the scan. All right. Okay, number 8. What about subacute air? This is sort of interesting, right? It took me a while to get a good image, but let's say you're looking at this and you're actually palpating their chest and you feel those little crunchy things like for subacute air, and you go and look at them and you see this white line there. Is that the pleural line? Am I missing something here? What's going on in this particular picture? And what you have to keep in mind is that the subacute air is blocking the ultrasound signal, so it can't get a view of the ribs. And obviously you're not getting a good view of the pleura. So in this particular situation on the left, you see the two ribs and you see the pleural line and that there's no movement there. While on the right, this is just sub-Q air. Of course, the answer is the same for both. There's a chest tube coming in at some point, but it's important to understand the distinction between these two types of images. All right, number 9. What about ascites? Okay, this is usually an autoped situation. A car has hit a pedestrian because this pedestrian has liver failure and there's a bunch of intraperitoneal fluid. Anyway, that's the person's baseline. And so you get this picture. Of course, you can see the liver tip here and you can see all these floating loops of bowel. And then you have the sort of picture where it's anechoic, but then there's this echogenic material and you're going like, I don't know, is it ascites or is it blood? And this is the time they have to pull out the steel and just stick a spinal needle into their belly. It's the easiest thing in the world to do, and pull it out and see if it's ascites or it's blood. So you get a procedure out of it too. But that's a quick way to answer that question. And bear in mind there are other non-hemorrhagic accumulations of fluid or intraperitoneal fluid from trauma. You can have a ruptured urinary bladder, which in isolation, it's not an operation. You just let it heal. You also get ruptured bowel. That's obviously an operation. Or you get a ruptured cyst, and the classic one is like the big renal cyst. The big hepatic cysts, they tend to bleed, but the big renal cysts, you don't really do a lot with them either. All right, getting close to the end of the pointers here. Number 10 is actually going to be a little case. Now, here's a guy who's at work who falls quite a long way. And he's picked up by EMS and he has a head injury, so he's intubated. And you can see he's tachycardic and hypotensive. And he's got this badly deformed right lower extremity. You do your comprehensive FAST exam and you don't get anything. And you say, let me go look at that leg. And as you can see here, here's the femur and here's the other end of the femur and all that clot in the middle. And here's the transverse view. Here is the femur and here's the other part of the femur and that clot in the middle. So it's a super way to look for femur fractures. And we all know you can stick a lot of blood in a thigh, particularly in a big person, and everybody doesn't pay attention to it. And maybe that's why they're in shock from all their bleeding. Number 11 is another case, and this is the final pointer. It's a car accident involving a 60-year-old woman. She's tachycardic and hypotensive, so she's in shock. She's got a lot of facial trauma, got a bad head injury. She's intubated in the field. She comes into your facility. She's got a positive FAST exam. They're going to take her off to surgery. And what happens is that you're looking at this face going, what's going on here? And so you go look at the eye, and this is what you see. Now, you may not recognize it as normal or abnormal, but I'll tell you, that's a real abnormal eyeball. And this is what's called flat tire sign, because that's what happened to that poor eyeball. It's been flattened and ruptured. It's hard to break an eyeball, but they're actually very, very hard to rupture, but that's the ruptured globe. And, after she gets out of surgery from original procedure, they go ahead and take her to CT, and you can see right here on the left side of the screen, her right eye is ruptured. So something very, very easy to do in the resuscitation bay. Okay. Back to that opening case. Remember the opening case? This guy in the gun battle
was minding his own business. I thought he was minding his own business.
Yeah. Right. It's always two dudes. It's the dude brothers. The dude brothers are back in town. And so the dude brothers shot this guy, and we said, oh gosh, he's in shock. And we do the right upper quadrant. Now, of course, we say, hey, very, very positive right here. Yeah, you can see it kind of making its way towards the liver edge. We go to the left. And initially, you may not say there's much here. This is the kidney, this is spleen. But if you do look, there's some fluid right here around the inferior pole of the spleen, right there. All right. And here's the pelvis. And this is impressive because this is the bladder. This is all blood up here with bowel intermixed. And of course, this is a transverse view through the pelvis. Then we also got the sagittal view with this as well. And you can see this is the bladder here. And then there's all sorts of fluid and this sort of echogenic material, which we assume is clot superior to the bladder. I should say cephalad to the bladder. Okay, so you have this information. What's your next move? Well, this is abnormal hemodynamics with a positive FAST, and this guy needs to go to surgery, and he did. And the bullet had gone right through his right renal pelvis, which is why he was bleeding so briskly. And of course, he was salvaged and saved so he could go meet with the dude brothers, go seek his revenge, as it were. All right, that's the end of this. I got a few final thoughts for you. Right upper quadrant, most sensitive. This is where you're going to start. If you had to learn one thing to do about trauma, learn this view. Okay. This is the money view. This is the one you get positive most of the time. Left upper quadrant, not sensitive, very specific, but don't rule out somebody. Oh, I fell off of something. I struck my left flank and I'm going to ultrasound is negative, send them home. No, 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 no. CT, don't ever trust your ultrasound left upper quadrant. Chest x-rays, in a word, 3 words. They suck. That's 2 words. They suck. Don't rely on them. If you want to see where ET tube and your chest tube is, that's fine. But you're not going to use them for hemothorax or pneumothorax. Repeat the scan. If we haven't said it enough, we'll repeat saying the same thing about repeating the scan. Repeat the scan. And finally, this is my new toy. I have the PAL, the phased array linear array transducer. I don't know if you can see it, but there's a linear transducer and a phased transducer. This is what I carry in my pocket at work all the time. This is pretty typical for us in a trauma scenario. You know, you got like a feeding frenzy in here, and here's the old cart-based system, and you have to kind of lean in and create a space for yourself. I don't have to do that anymore. You know, I can just get in there with the rest of them and scan, and it's so convenient. Everybody says, "Oh, that's so cool," and I go, "You're right." So I think that's the end of what I have to say. Thank you so much, everyone. Of course, I'm sticking around for questions and other sorts of things, but thanks for listening to me.
Thanks so much, Tom. While we're getting set up here for a live demo, we wanted to kind of put it out to you. We know we have people from all over the world, and like we saw, there's a lot of you here. And we've done a long series with Dr. Cook, but what else would you want to learn about ultrasound for our next webinar? Help us help you kind of focus the topic and focus the content. Interesting in ocular ultrasound, interrogating the valves for us non-cardiologists, or coronary artery disease. You can select any of them that might sound interesting to you, and it will help guide our content development for the next webinar. If you've been to some of our other ones, you know how high quality we like to produce. So this will help us. And we'll go ahead and close that one out. Great. And then one other idea we've thrown around is, you know, we share all this information with our expert teachers online, but nothing really substitutes for that live hands-on education and learning to generate images with some expert guidance. And so based on where you are in the world, is that something you might be interested in some kind of collaboration where you might want to attend a live course that we could help you learn to generate images and interpret them? Please click. I mean, if you're in multiple locations, great, but I assume these will mostly be a single answer based on your location in the world. And this will help us sort of also cater future educational offerings to you guys and really help everybody's skills out there. All right, we're going to close that out. Thanks so much for your participation. Stay tuned for the Q&A at the end. But first, we're going to hand it over to Shelley Gunther for a quick demo.
Thanks, Oran, and thanks, Dr. Cook. It was a lot of great content, as always. I'm just going to just show you a new feature called the eFast preset here, but I'm also going to show you, as I mentioned before, the PAL, the new PAL phased array and linear scanner. And I don't know if you can see this or not if I hold it at the right angle, but there's a linear array here and then a phased array here. So, and it's as easy as just programming one of the buttons here to switch arrays during your exam, or by switching the preset, it'll switch automatically for you. So just show you how this works. And I'll just, so I'm using the eFast preset here, as I mentioned. And if I go down to the right upper quadrant here in Morrison's pouch, we, I've selected the abdominal preset. And so it's just optimized my imaging for looking for free fluid in the abdomen. And I'm just doing kind of a sweep back and forth. And as Dr. Cook mentioned, we're seeing the tip of the liver here, as well as Morrison's pouch. And as well, we can see above the liver here as well. Great. And then from there, if I want to go in and do a cardiac exam, I can just select that heart and then just go up and look at the subcostal view here. And it's optimized it for cardiac imaging. And then the same thing, if I switch over to the lung preset, it's going to change over to the deep lung preset. And so we can look in multiple areas here, but again, optimized for lung imaging. And what I talked about earlier, if we want to look more closely for lung sliding, I can just do a program mine for a double click on the scanner here for shallow lung scanning. And now that's switched over to the linear array portion of the scanner. And it just happens instantaneously. It's really fast. And alternatively, I could have gone up and just selected that preset, but then that makes I have to take my hands off the scanner. So again, if I just do a double click on my top button on the scanner, we're back into the lung deep setting. Good. So that's the PAL for you and the new eFast preset. So I will just make my way back over to my desk here.
Great. And a reminder to keep using the Q&A. We have lots of great questions here, and we are going to get to those by the top of the hour. Any that we don't get to, we can either stick around for a couple extra minutes, or we'll make sure to follow up with you after the webinar. And in the meantime, another thing that can help us and help the Clarius team is if there's any additional information you would want, the Clarius team would be happy to reach back to you. Here's a poll about possible information that could help you learn more about the Clarius probe, and you can click any of those that would help you make a future decision.
Now, while you complete the live poll, let me tell you a little bit more about the new Clarius PAL HD3 dual array wireless scanner for whole body ultrasound. Like I mentioned, it's FDA approved and now cleared in the EU and Australia. As I showed you, it has an innovative dual array wireless design that fuses a phased array and a linear scanner on a single head to provide you with lots of versatility. It stands out by offering a really broad frequency range from 1 to 15 megahertz, and it makes it the ideal handheld for clinicians seeking the ultimate in image quality and diagnostic flexibility. Clinicians say that they can perform 95 to 99% of bedside ultrasound exams with a single scanner, eliminating the need to swap probes, reduce interruptions, and improve workflow continuity. With Clarius, there's no wires to get in the way or infect your sterile field. For cleaning, Clarius is IP67 rated, waterproof, and fully submersible for rapid disinfection. Lightweight and ultra-portable Clarius scanners require zero footprint and feature the latest antenna technology for the most reliable direct Wi-Fi connection to iOS or Android phones and tablets. With no wires or bulky carts limiting monitor placements, you can easily share real-time imaging and talk patients through their exams, fostering engagement and boosting their confidence. Clarius delivers wireless scanners with a complete ecosystem that includes an easy-to-use app for your iOS and Android devices. Available with our membership, exam management is easy, to saving images to the PACS server through current DICOM web standard or using Clarius Cloud. Now, we'll give you just one final minute to complete the poll here while watching this fun Clarius video.
Chosen one, I can get it done. Zip, bang, boom, pow, every mission one. Got that laser vision, cause I'm born a legend. Get up, get up, get up, let's roll. Ooh, I'm a drive-through thriller. Ooh, no one else does it better. Watch me, watch me, watch me, let's go. I'm stronger than you've ever seen. I got superpower. Let's go. I got superpower. Let's go. Super, super, super power. I'ma take it higher. Super power. I can take it there. Let me take it there.
Great.
Nice.
All right. So Dr. Cook's probably dancing in the background right now. We can't see him. One more quick poll before we jump to questions. And this one is an invitation to pre-register for the next eMed webinar. Dr. Frankel will be tag teaming with Dr. Brian Johnson, and the title is POCUS Skills for Your Next ED Shift, 5 Ways to Elevate Patient Care. So this will be an interactive webinar where Drs. Frankel and Johnson will explore the essential ultrasound skills you need in the fast-paced emergency medicine setting. So I'd like to welcome back Dr. Frankel and Dr. Cook for the Q&A session. And again, just use the Q&A at the bottom. And Dr. Frankel, I'll invite you to moderate, please.
Yeah, let's jump in. Lots of great questions here, Tom. See what we can do. First question is, what about retroperitoneal trauma and injury to the kidneys?
Doesn't work is the short thing. I mean, maybe if you see something, you could say it's specific, but it's not really a great tool for the retroperitoneal injury.
Yeah, I have a memorable case of someone who got hit by a train who was clearly hemodynamically unstable, but with a negative fast. And the question was like, where's the blood? And that's where it was in the retroperitoneum with
Yeah,
shattered kidneys.
that's the one you're going to resuscitate and then get to the scanner. And that may
Right.
be one
Yeah.
that you want to even embolize as opposed to
Right. Instead of opening them up.
Yeah.
Yeah, great. Can you differentiate between, maybe I'll combine some questions in the interest of time. So differentiating urine, blood, and clot, like how can you tell one for the other, or can you?
Yeah, it's that needle thing. It's called steel. You find a pocket of fluid and if you have enough, obviously. If you don't, then you can't do that.
Mhm.
But you can't. And so that's where, okay, I got some fluid in there and my patient's unstable. That's going to get a laparotomy, and or they're stable and you're thinking that, well, it could not be that. Then that trauma surgeon, obviously the surgeon's going to make the decision. They're the ones got to cut them open, but they may decide not to do that. And I've seen these bladder injuries, you probably have too, where they can look pretty impressive, but they see the injury and they think that that's the problem and the patient's stable. They just let them heal because urine is sterile, so they don't care about
it. Right. What about, how often do you use ultrasound for fractures in your trauma patients? You showed the kind of femur fracture. Do you use it for other fracture assessments?
Well, I mean, isolated trauma, like we've done, we actually did a study looking at it for pediatrics for long bone fractures. It really was more of a triage sort of decision where the kid fell and, it hurts right here, and we can look very quickly with ultrasound and we don't see any evidence of fracture. And either we can prioritize that patient in terms of they should go to x-ray sooner or later, be seen sooner or later, or if we're really crowded, they can say, look, we don't see a fracture. Do you want us to just get you an appointment to follow up tomorrow with orthopedics to see them? But mostly what I'll use it for in the trauma bay, when you have a real sick patient, obviously the thing we worry about the most is femurs, because you can get so much bleeding there, particularly with very obese people. They will hide that blood in their soft tissue, and it gets very, very tricky.
Great. Any tips or pearls? Can you differentiate between a simple or a tension pneumo with ultrasound?
Yeah. So a simple pneumo doesn't really change the vital signs, right? We all see patients with pneumothorax, and maybe they're a little tachycardic, a little tachypneic, or whatever. Tension pneumo is a life-threatening event. Those patients are hypotensive. What you have is obstructive shock, and you've got so much pressure in the chest that the heart can no longer load. You can't get any fluid into the right heart, which means you can't get any preload in the left. Your cardiac output drops and you get real sick. That's why it kills you. Now, the other point to remember is when you have a lot of air in the chest, you can't see the heart. So that should be a tip off. A lot of times I'm in traumas and I try and look at the heart and I can't see it in multiple different views. That's telling me that something's going on. And a lot of times it's just sub-Q air, but it could be air in the mediastinum, it could be air, but there's air somewhere where it shouldn't be.
And to tag team that, what are those other views that you're doing on the heart, if you're trying to kind of obtain?
Oh, of course, parasternals and apical views. Apical view is another one that comes in handy because it's kind of away from the chest, if you will, and not in that center part of the chest, so you don't get into other people's way. Although I've discovered, since we've gotten better at this, is that they want me to tell them as quickly as possible what the problem is if it's there. So it really is right at the beginning of the resuscitation that I go through that.
Mm-hmm. We're nearing the end here. I'll try and squeeze in. Have you ever seen an aortic transection on the MVA after an MVA? I mean, all the ones I've seen were dead, but have you ever seen one live?
Yeah, that's fatal. And of course, you run into these other things where you're suspicious that maybe you do have an aortic dissection. I have had one case that's always a little bit difficult to say. I'll tell you one that was really wild was I had a blowout of the aortic valve. So this is what happens when the patient's chest impacts the steering wheel when they are at the end of diastole. In other words, the heart is just full of blood. It hits the chest, it jacks up the pressure so high that it blows out the aortic valve. Excuse me, I misspoke there. Blows out the mitral valve, tears off the papillary muscle. And what those people come in with is horrible pulmonary edema. But you're confused because you don't know if it's a pulmonary contusion or pulmonary edema. Then you see that mitral valve just flopping around like crazy. And that tells you, whoa, they blew that valve. And that, again, is at least that particular patient died. But you have to be open. You open up your mind to thinking about other things sometimes.
Yeah, important, right? To kind of keep the open mind, and I use the ultrasound maybe as your cognitive correction mechanism. That's kind of how I try to teach it. Is you would get these hypotheses and then you see data and you're like, wait, that doesn't fit.
Yeah. Well, you have a list of things you're walking in. What can I wipe off? What things can I strike off my differential within 3 minutes?
Right. But I don't think, ruptured papillary muscle, it's usually not on my differential, I guess, in blunt trauma, but yeah. All right. Maybe I'm going to squeeze in one last question. How much training do you think is required? This comes up kind of everyone. People want to know how to get more training, but like, where do you think the number is in terms of scans people need to do to feel comfortable doing this kind of scanning, trauma scanning?
Again, it's dependent on how much trauma that you're seeing. So at my place, you could get 20 or 25 studies and be really good, particularly in the right upper quadrant, which I think is just the one thing you got to learn. If you're not in those settings, try and find things, particularly patients with ascites. Okay, here's a classic case. They already have fluid in their tummy. So take the time to go look at those patients and drill into your head where that fluid's going to accumulate. And I think that would help you a little bit. But with all these different skills, as you know, Ron, it's a little dependent on the person about how quickly they pick it up. But I will say this, it ain't hard. Okay. If I can do it, almost anybody can. And it's just a matter of perseverance and repetition, and you can use this quite easily.
Great. Okay. I'm going to cut it off there to respect people's time. Thanks so much, Dr. Cook. And Shelley, you want to close us out here?
Yeah, great. Thank you. Yeah, repetition, practice makes perfect, for sure. So thank you, everyone, for all of your questions. If we didn't get to your question or you asked for more information on the poll, we'll follow up with you in the coming week, and you'll receive a PDF copy of the slides and webinar recording as well. So keep an eye on your inbox. And I'd like to thank Dr. Cook so much for sharing his best practices, and a very big thank you to all of you for joining us. And thank you, Dr. Frankel, for hosting. If you missed earlier webinars in Dr. Cook's series, we invite you to visit clarius.com and webinars, and complete our closing survey, please, to provide feedback so that we can continue to bring you educational webinars like today's. So until our next event, keep scanning, have fun. Thanks again.